This panel is talking about Affordable Care Act implementation. Those of you that have been through this process, and I'm sure we'll hear about this over the next few minutes, know that each of the states is handling this a little bit different, and there's probably places where every one of those states could do a little bit better job. And it's one of those issues that is both federal and state, and the state part is very, very important. So I apologize because I don't know who is going first, but whoever's got the best slides, you may go first. So Joel, could you introduce yourself and let us know?
Good morning. I feel like I was just speaking to you last year. Oh wait, I was. Thank you. Thank you all for being in DC. It's really important what you're doing, and I know Julia and Jen and everyone who's worked very hard on this conference appreciates the fact that you're here in DC to stand up and not only advocate for what you believe in, but to also hold people accountable. And so I applaud your efforts. We're happy to support everything that you all are doing. So I just got off a plane with a couple hours of sleep, so if I'm rambling, just throw something at my head. But I'm here to talk about an easy subject, the Affordable Care Act. So last year, and the comedy continues. Last year, I was trying to walk through the law, and I think I got to like slide 2. And the questions started flowing in. So what I'm going to try and do is just really kind of go through this real quick. And then Robert's going to talk about some of the implementation issues, what's happening on the ground at the state level, and then we can kind of have a dialogue and go back and forth. So I think we all know insurance is changing fairly dramatically. Now, 2014 is kind of the first year that a lot of the new insurance requirements are taking effect. Basically, new plans have to be standardized around 10 categories of essential benefits, things like physician office visits, hospitalization, prescription drugs, all the way down to things like habilitative care, mental health benefits, maternity coverage, things like that. And plans are also being standardized around the value they deliver, known as actuarial value. And so if you go onto an exchange where you purchase your health plan, you'll see bronze, silver, gold, platinum. These are different levels of coverage that basically give an indication of how generous the plan is. So for example, bronze level, 60% of the plan will cover about 60% of the benefits covered under the plan. You would pick up 40%. If you go platinum, the plan picks up 90, you pick up 10. There's an out-of-pocket limit, which we'll get into. It's a major issue, I think, for a lot of folks in the community. But there is an out-of-pocket cap of about $6,350 for individuals and about double that for families in 2014. That will increase with inflation over time. There's also a deductible limit in the small group market. It's not being implemented this year, but it could come coming back into play. And then there's rebates. So a plan has to cover a certain percentage of medical costs and keep their administrative and profits less. If they fail to meet the limit, basically they have to pay a rebate to you. And so those are pretty major changes. And what we're seeing, and I'll go through this, I'm not going to talk about all that. I can't read that, you can't read it, but basically plans are required to offer this new standardization of benefits around these categories, and what we're seeing, the practical effect we're seeing on the ground, which Robert's going to talk a lot more about, is generally premiums are a little more expensive. Plans made an affirmative decision to go with lower price points based on the categories of benefits they had to cover. As a result, it's kind of like squeezing a balloon. If you keep your price point low on the premium side, you got to make it up somewhere else. And so there's higher cost sharing. This is, if you go on the exchanges, you see higher deductibles than what you typically see in an employer plan. You see separate deductibles for drugs. You see formularies that don't really look like normal formularies. There's 4-tier formularies, 5-tier formularies. What that means is at the 4th and 5th tier, drugs are much more expensive. They require much more cost sharing. And we see coinsurance, the average is about 33% on the tier 4, and copayments, which is $1 out-of-pocket charge. And most plans are using those. About 59% of plans are using cost sharing in the formularies. Now, why is this important? Well, pretty much everyone in this room is required to have coverage that meets the stuff that I just talked about. And if you don't, you got to pay a penalty. It's known as the individual mandate. And so that took effect this year. You've got time to sign up. People keep talking about the March 31st deadline. That's 1 month from now, basically. If you don't have a plan, if you don't have minimum credible coverage by March 31st, you could be subject to a penalty. And employers are supposed to have a mandate as well. That is, if you have more than 50 employees, you're supposed to provide a certain level of insurance coverage to your employees. If someone in the company gets coverage through an exchange plan because you're not offering a minimal coverage that's affordable, you could end up paying a penalty. And that penalty will vary based on the circumstances, but it's basically a per employee charge. And I think what we're hearing from a lot of the employers is they're weighing the cost of that penalty against the cost of providing coverage. And they're making a decision, which is completely rational. If I pay less on the penalty, maybe it makes more sense to send employees out into the exchanges, knowing that they'll get coverage because there's guarantee issue, knowing they can't be denied based on their condition because there's no longer coverage denials for pre-existing conditions, and knowing that that coverage will meet at least a minimum level of benefits, 60, 70, 80, 90%. And they have to cover 10 categories. Or there's some employers that we hear from that say, we've still got to compete in the marketplace. And health benefits are still a very attractive benefit for skilled labor. And so we want to use that to draw in skilled labor. But the problem that we see is that both these mandates are creating a lot of distortions. And the employer side in particular, your full-time, like I said, if you have 50 or more full-time employees, those people are gauged based on how many hours they work. And right now that level is 30 hours a week. Slightly less than the standard in France, I would note. Just saying. We can get it done. Remember Rosie the Riveter? What happened to that spirit? Anyway, sorry. Soapbox, we'll take it away. So 30 hours a week, and so it creates these distortions where we see some employers, including some state employees, some universities, cutting back people to 29 hours a week. And so that's having a real impact on wages. And it means that they're not being used to calculate the employer mandate, which means they may not be getting health benefits. And so that's an issue. I think we're going to see Congress address that within the next couple of weeks, at least in the House. And Harry Reid, the majority leader of the Senate, has said that he's going to allow a few votes on legislation this year. What was that? Okay, so this is how it gets calculated. Like I said, this is a really easy law to explain after you just get off a plane after a couple hours of sleep. But basically, you go through a process for determining how the penalty applies. So where do people get coverage? Has anyone heard of healthcare.gov? It's a website. Well, exchanges. Think of them as a shopping mall. It's got a lot of stores in it. And think of the stores as different health plans. And within the stores, you can buy different articles of clothing. Think of those as the different levels of benefit. But the mall is the exchange. And so you go to the mall, and you theoretically can comparison shop and figure out which plan works best for you. And obviously a rocky rollout. We've been tracking enrollment numbers since October. And right now, a little bit off of the target of 7 million people signed up. Robert's going to get into some of the enrollment numbers. But basically, most people are choosing silver plans, and most people are getting premium subsidies. And you say, where is this happening? Well, this shows you how people are accessing their benefits. And either the state's running it or the federal government's running it. The federal government's running it in most states, or the federal government is partnering with the state to share obligations. And there's great examples out there of exchanges that work very well. And there's really horrible examples of state exchanges that work not so well. And then there's healthcare.gov. And healthcare.gov, I think, is getting better. The one outstanding major issue, I think, is the back end. How do we determine that people are actually eligible for subsidies and then get the check to their insurance carrier to ensure the insurer is getting paid based on the enrollment. So this map shows you where the enrollment is. And the green, or kind of colorblind, it's like a yellow-green, I guess. That's where the highest enrollment is. And so you can see those are pretty big states. And that's not counterintuitive. We would expect more enrollment in those states just because they have higher population. But you can see also the distribution is interesting because we're getting some sign-ups in less populated states and fewer sign-ups than I think we would have expected in some of the more populated states. So all these slides are going to be available, I think, after the conference. You can take a look at your own state. We'll post them online too for you to take a look at it. But subsidies tied to income, the higher your income, the lower the subsidy. Okay? More assistance for lower income. There's two issues here. The first is there's a lot of people making hay about if you earn one more dollar, you lose your premium subsidy at 400%, say. So there's a disincentive to earn that one additional dollar. Or to earn at, say, 250%, one additional dollar to get you up into the 300% category. It's a marginal cost, some economists talk about. And CBO basically came out with a report recently that said fewer people will work as a result of this subsidy structure. And Republicans jumped all over it and said, aha, we're destroying jobs. And Democrats said, no, we're providing assistance to people. And so you'll hear more about this as we get into the nonsense later this year, otherwise known as elections. But the other thing is that there's also cost sharing reductions. So remember I said there's high deductibles, high cost sharing on some of these plans? Well, there's cost sharing reductions based on your income as well. And so part of those high deductibles may be taken away and subsidized by taxpayers at the lower income levels. Wow, I'm really not going to talk about that. So what's the effect? This is all very confusing, right? Like it like boggles the mind because there's so many moving pieces, and I haven't even talked about Medicaid or Medicare. Sorry, let me talk about Medicaid real quick. Some states have chosen to expand their Medicaid programs. The federal government said we'll pick up the cost basically for a few years for incomes if you expand your Medicaid program up to basically 138% of federal poverty. Where do the subsidies kick in? Right at that line. So theoretically, there's no gap there, right? You can get into Medicaid or you can get into a subsidized insurance plan. Well, what's the problem? Some states didn't expand their Medicaid programs. So if you're in this gap, you can't get a premium subsidy and you can't get Medicaid. So there are people falling through the cracks here that I don't know if there's going to be opportunities to address that other than the state level. Because it doesn't look like Washington's going to do a lot of fixing on the ACA anytime soon. So the impact here is there's a lot of good things happening. There's a lot of cost increases. There's access issues. There's kind of like a seesaw, right? And there's like a whipsaw effect. There's good things. There's bad things. There's a practical impact of the policies at play here. And so we can talk about the woes of healthcare.gov and people having problems signing up. But what I talked about and what the insurers are offering is a result of the policies in the underlying law, right? The three main cost drivers here, what's impacting insurer behavior is the essential health benefits, the requirement that you cover all those benefits. It's rating rules, the rules that say you can only vary your premium based on a ratio. And so you can't charge the oldest person more than 3 times the younger person. And it's the actuarial value. It's the 60, 70, 80, 90. And so what we're seeing, like I said, is higher deductibles. The average deductible silver plan, which is where most people are signing up, $31.32, which is high. That's a high deductible based on what people are typically getting in through an employer. Average copay of 23%, average coinsurance 21%. So if the doctor's office visit is $100, you're paying $21 on that. Higher copays for specialists, and then this cost sharing on the specialty tier, 59%. And so there's 2 issues that I want you to consider. The first is the specialty tier separate drug deductible issue. If there's not more flexibility granted on the three main cost drivers, I think you can see those problems increase. So you'll see higher cost sharing next year, especially if the risk pool is sicker in the exchange plans. And the second issue, I think, is an issue we talked about last year. I don't think it's been addressed. But that's a lot of, how many people go to out-of-network specialists or physicians? You know, a lot of people, right? That the expenses in the out-of-network don't count against the cap, the out-of-pocket cap. So if you're spending all your money out-of-network on a specialist, it's not counting towards that cap, which means theoretically you're exposed forever. That's a problem, and I don't think that's what the authors of the law intended when they put the cap in place.
Joel talked about ACA from a federal perspective. I'm going to talk a little bit about ACA from a state perspective. And when I'm talking about state implementation of ACA, I remember my days as a graduate student where your professor came from a meeting at NIH or something and had a brilliant idea and said, just do it. You know, and that's what it feels in the state level. The federal government created this, and now the states have to implement it. And what I'm going to do today, I'm going to share a lot of information with you, data-wise, very objective type of information that is out in the marketplace, and then we can have a discussion about what is really happening in the state level with regards to the implementation. So starting, you know, there's been a lot of consternation about enrollment. You know, it started with the website not working. The initial numbers were sort of low with regards to the people enrolling into the exchanges in the state level. What we're seeing most recently, and the most recent number is about 3.3 million, and as Joel mentioned, what we're going to see is that by end of open enrollment, that the administration is going to get close to the numbers that they had projected with regards to enrollment. They're going to get close to about 6 million. There are about 3.3 million, and every month there's more and more activity in the website. So the website's getting better, and the enrollment numbers are going to reach. However, not all the news is good news. So what the administration is seeing, what we're seeing in the state level, is that young people are not enrolling. The average age, the majority of enrolls are 45 years and older. So what you wanted initially, remember this whole thing was constructed based on getting 20-year-olds enrolled in the exchanges, and that's not happening. The other thing that we're seeing in the state level is that more females than males are enrolling, about 60-40 clip. This is not surprising to me, considering how we know males treat their healthcare issues in the average. You know, they never see a physician until they're almost dying, right? And the female is the one that generally has much more conscious about receiving health care. So this is not surprising, but this has ramifications with regards to risk pools and things like that, with regards to who's enrolling from a male perspective into these insurance programs. The other thing is regarding benefits. Where are they enrolling? So what we're seeing is that majority of people are enrolling either in bronze and silver plans. Not surprising, silver because that's where the subsidies kick in, so most people are choosing silver to be able to get the subsidies. And 80% of people who are enrolling are receiving subsidies. So this is not an individual who doesn't have insurance, who's basically going in and paying full price. Federal government's helping quite a bit here for the enrollees to happen. We touched a little bit about Medicaid. I'm not going to get into too much detail because I think Joel did a really good job of covering it. The administration claims that there's about 7 million Medicaid enrollee eligibles out there. What we're seeing is that there's actual numbers about 1.1, 1.2 million. And the Medicaid enrollment numbers are going to differ from state to state because some states have decided, as Joel mentioned, to expand their Medicaid programs and include all the way to 38% of poverty line, right? And some states haven't. So the Medicaid is going to be in flux with regards to the number of enrollees over a period of time. We're also seeing in the state levels a wide variation in premiums. So not only within the metals, so obviously we assume that you go from bronze to platinum, the premiums are going to be more expensive, but what we're seeing is that state to state, the premiums are varied all over the map. So it's not very consistent exactly what we're seeing, that there's one state level, that premium level that goes on. But the most troubling thing is this, which Joel touched on, is the average deductible that are being spent by patients is about $2,500 out of pocket. And if you compare that to what is the employer-sponsored plan deductibles, which is about $1,135, there's a significant difference. It's almost more than twice what people are going to spend in deductibles compared to what employer-based plans are. So keep that in mind, because one of the slides at the end, I'm going to address this issue and what the concerns are. Again, more data. Average copay out of pocket for physicians for primary care is about physicians is about $21 and $40, and this only includes, as Joel mentioned, if you go out of network, it doesn't apply to your out-of-pocket costs. Same thing with pharmaceuticals. If you go alpha formulary and you try to access a drug that is non-formulary drug, that does not apply to your out-of-pocket costs. Specialists, more expensive, obviously. It's about $41 and over. With regards to the expenditures for specialists, not surprising. We pay more for specialists in the private marketplace too. And then drugs. Drugs, again, variation, things that we don't see generally in the private marketplace. There's many more tiers. There's cost sharing or co-insurance involved. And not surprisingly, as you go from bronze to platinum, cost sharing drops, co-insurances go away. Same thing as we see in the private marketplace, but the major difference is that what you see in the private marketplace is that as you go to a better benefit, you also get more access. In this case, you don't get more access. So if you go from a bronze plan to a platinum plan, you just get the cost sharing lowered. You're not going to get a better network of physicians to work in. So that's also been an issue. So major concern. What we're seeing is a trend that the commercial marketplace and Medicaid even that may have more generous programs are going towards merge into a catastrophic plan. And what we're seeing is that the exchanges are in the middle. So our worry is that there may be a spillover effect of employers, just like Joel mentioned, going to a much less valuable or much less robust plan for their employees. So having said all of this, there's a draft letter that came out a couple of weeks ago. CMS is already looking at issues and trying to address them as they come along. So there's 5 areas that they've identified in this draft letter that came out on this, February 4th. And you guys should all be aware of it, because if you're working as organizations trying to influence it, this impacts a lot of it. So they try to address discriminatory formulary design. What they're seeing, and this is not surprising, is that there's a lot more prior authorization, step therapy, a lot of those methodologies going into formulary plan designs, and they're trying to address that. Yes?
Sorry, could you please explain these terms in lay
Sure.
terminology, formulary, co-insurance?
No
all
problem.
These,
So formulary is
what do you mean?
formulary is a list of drugs that a payer, a PBM, a health insurer will have that are approved medications that they will cover. So they will maybe at different tiers. So there may be a tier 1, tier 2, tier 3, tier 4. Generally, tier 1s are generic small molecule drugs, which are very inexpensive. Then tier 4 will be much more expensive, like biologics and specialty medications. So the tiers are varied based on cost, and it's a very cost-driven structure. So the formulary plan design, what they're worried about is that not only that there's this very wide variation in what they're seeing in the exchanges of the different tiers, but that their methodologies are being used like prior authorization, step therapy, that fail first. All these terms are coming into play, which are basically mandating a patient to go through several other therapies before they get the drug that their physician wants them to get. So CMS is already looking at this as an issue. In their call letter, they've pointed it out as one of the areas of concern. Medical drug benefit. So what CMS is trying to do in this case is to distinguish between a medical benefit and a pharmacy benefit. There are certain drugs that are administered in the physician's offices that are under the medical benefit. So CMS is trying to distinguish between the two arms and say, you can't crowd the formulary by putting all together and saying, look, I have this robust formulary and list of drugs that I cover. Well, some of the coverage is under the medical benefits. It's not really under pharmacy benefit.
What's CMS?
Center for Medicaid and Medicare and Medicaid Services. Coverage of non-formulary drugs. This is with regards to the purpose of making sure that if a patient goes from one plan to another, so we're going to see a term that you're going to hear a lot more is churning. So if patients are going to be in a private insurance, the company like Pfizer, like mine, is going to decide that they're no longer going to offer the insurance anymore, and I'm going to go to the exchange, so I'm going to change plans. At the same time, my benefits are going to change, so I'm going to go from one set of drugs that I had available to another set of drugs. So CMS has identified that as an issue because they're going to see that patients are going to bounce between Medicaid and private insurance. Patients are going to bounce between private insurance and exchange insurance. So there's going to be a lot of changes in scheme and coverage decisions for patients. So Medicaid has said, CMS has said that, and they started this last year actually, end of last year, to say voluntarily you should cover at least 30 days of drugs even if it's not on formulary. So if a patient goes from Plan A to Plan B, during that transition of 30-day period, they should get the drug no matter whether it is on the list of covered drugs or not. What they're trying to do now is mandate that process to say, if you're going to go from Plan A to Plan B or from Plan A to Medicaid, that for the first 30 days, there should be some coverage to maintain the patient. And this is not unheard of, right? It's soft landing, trying to get the patient accustomed to a new plan, at the same time maintaining them on their therapy so they can go through any cost-sharing issues that they may have, or they may have to go through prior authorization or step therapy. Formulary transparency, major issue. This is something that Part D did it really well, which is allow patient upfront to know what's on the formulary, on the list of covered drugs before they sign up to a plan. This doesn't exist in the exchanges. There's only one state, Nevada, that allows a patient to go on and go on the system in Nevada and look at what drugs are available on the formulary and before signing up. So what they're trying to do is to say, you need to make the list of drugs that you cover available for the patient to look at before they sign up with the plan. So there's an element of transparency.